So today I'm going to be talking about the diabetic foot. So some of the overview, we'll talk about some diabetes, some facts about diabetes. We'll talk about some risk factors for ulcerations, amputations. We'll talk about the diabetic foot infection and what it involves and how to treat it. We're also going to talk about a condition called Charcot-neuroarthropathy, which is a complication due to untreated diabetes. And we'll talk about some treatments and preventions, some foot care guidelines, and some diabetic shoe gear. So what is the diabetic foot? Well, the whole World Health Organization defines it as the foot of a diabetic patient that has the potential risk of pathological consequences, including infection, ulceration, and destruction of deep tissues associated with neurological abnormalities, various degrees of peripheral arterial disease, and metabolic complications of diabetes in the lower limb. So there's about 425 million diabetics worldwide. 1 in 2 adults with diabetes are undiagnosed. 1 in 11 adults have diabetes. Every 7 seconds, someone dies from diabetes. An amputation occurs worldwide every 20 seconds. A person with diabetes has 34% chance of developing a foot ulcer in their lifetime. More than 50% of diabetic ulcers become infected, and 20% of those diabetic foot infections result in an amputation. And then 80% of non-traumatic amputations in the United States yearly are due to diabetes. Diabetic foot ulcer patients are twice as costly to Medicare as those with diabetes alone. The cost of a diabetic foot ulcer is greater than that of 5 most costly form of cancers, including brain cancer, pancreatic cancer, ovarian cancer, esophageal cancer, and stomach cancer. In the US, $176 billion is spent annually on direct costs for diabetes and $850 billion worldwide. Diabetic foot ulcers double the mortality and heart attack risks and increase risk for strokes by 40%. The relative 5-year mortality rate after a limb amputation is 68%. 60 to 70% of diabetics will develop some nerve damage in their lifetime. So uncontrolled diabetes can lead to a variety of things. It can lead to neuropathy meaning abnormal nerve function, which can lead to lack of sensation, numbness, tingling, burning, and severe pain. Peripheral arterial disease, which is decreased circulation in the lower extremities, which can lead to gangrene and non-healing ulcerations. You could also have something associated with that called small vessel disease, which is a very complex condition where the small arteries and vessels in the body aren't getting enough blood flow, and there's not much intervention we can do to open up those vessels. With regular peripheral arterial disease, vascular surgeons are able to open up any occlusions and increase blood flow. But when you have small vessel disease, it becomes more challenging. Delayed wound healing, ulcerations, it increases the risk for postoperative infections and complications, and it can lead to amputations. So some of the risk factors include, uncontrolled hyperglycemia, which is sugars. The longer you've had diabetes increases your chance. Peripheral vascular disease, blindness or visual loss, chronic renal disease, and older age. Local issues include neuropathy, structural deformities such as like bunion or hammer toe, or flat foot deformity, trauma and improper fitting shoes, calluses. Calluses are pre-ulcerative lesions, meaning that when you have a callus, you're putting a lot of pressure in that area. And if it's not taken care of, it can break down and lead to ulcerations and infections. Prior history of ulcerations and amputations increase your risk. Prolonged elevated pressures and limited joint mobility, such as like arthritis. Risk factors for amputation is the same to that of ulcerations, with the added risk factors of infection, Charcot arthropathy, male sex, and ethnicity. Greatest rates in Blacks and Hispanics. So this diagram here kind of looks pretty complex, but I'll try to break it down into simple way. And it's basically what leads to amputations, right? So it starts with diabetes, and you can go down different paths. One where you have decreased nerve sensation, secondary to neuropathy, not feeling, um, you lose that feeling, you could step on something and get infected and not really realize it. And before you know it, you develop an ulcer, which can get infected, and then you get the amputation as a treatment to get rid of the infected tissue and bone. Trauma, if you have a serious traumatic injury, where you have difficulty healing the ulceration, the wound, because of the significance of the trauma, and having diabetes just decreases your chance of healing, can lead to an amputation. And then also, last but not least, the circulation. So diabetes can lead to peripheral vascular disease, which can compromise healing and blood flow, and lead down to ulcerations and amputations. So diabetic foot infection, the reason why they're complex is because they involve a lot of organisms. So this is kind of the most common organism seen in a diabetic foot infection. For somebody who doesn't have a diabetes, usually they can develop an infection. It's usually like staph or strep, right? Here you have all types of organisms that, we would have to, make sure that we cover, and that's why we would start patients on broad spectrum antibiotics whenever they have these infections. Redness and swelling may not always be present, but that's always something that the patient should look for, and us practitioners would look for. White blood cell count might not be elevated if the patient is immunocompromised. We always check all these inflammatory markers and wound and blood cultures to also help us figure out if the infections in the bloodstream, which is a more serious problem, that if the infection gets in the bloodstream, it could travel to different organs and other parts of the body. We always assess the perfusion. So there's a lot of these tests that we can order. And then we also work with our vascular colleagues to make sure that, the patient has adequate circulation so they can heal any surgery or any procedure that we may need, such as an incision and drainage to get rid of like any pus or infection, or, any elective procedure that we may need. Some imaging that we order to help us with diagnosing bone infection or skin and soft tissue infection include x-rays, MRI, and bone scans, and some of the treatments, like I said, incision and drainage of the abscess, debridement of necrotic or non-viable tissue, and then amputation to get rid of the infected bones so patients can get back to recovery quickly. So basically, this just kind of, there's a guideline that tells us what we need to look for to figure out how serious the infection is. If it's mild, moderate, severe. Typically, moderate to severe patients would have to go to the hospital. If it's uninfected wound, we would see the patient regularly in wound care in the office. And if it's a mild infection, usually we treat them with oral antibiotics. But once it gets in this level right here, they need IV antibiotics and more intervention in a hospital setting. So, this diagram kind of explains that, there's so many different pathways that we can kind of take with a foot infection. So, if it's a non threatening infection, usually the redness is less than 2 centimeters. These are things that we can treat in the office with antibiotics, with debridement, simple incision and drainage. But if the infection is very severe, and infections in the blood, where the patient's at risk of losing an extremity, usually we have to treat them in the hospital, and so typically if the erythema which is redness and swelling, is over 2 centimeters, and if there's any signs of like gangrene, usually we have to send those patients to the emergency room right away. So there's a lot of surgery that we can do on patients with a diabetic foot. Just because they have diabetes doesn't mean they can't have elective surgery, such as taking care of like bunions and hammer toes. Usually, if their A1C is at 8.0 or lower, we could certainly do elective procedures without increased risk for complications, such as infections or failure of hardware, things like that. But if the A1C is higher, usually we try to stabilize the patient before we can do any of these procedures. So, but typically surgery can be broken down into elective. So if a patient has a painful deformity, like I said, a bunion without an ulceration and with the sensation intact, that's considered elective. Prophylactic surgery is if a patient has a deformity without an ulceration and neuropathy, to prevent future problems such as like calluses and ulceration. And then there's curative if a patient has like an ulceration with or without an infection, such as repairing deformity or resection of infected bone, which is called osteomyelitis, or wound debridement with graft application to help heal a non-healing wound. And then lastly is an emergent surgery, such as gas gangrene or necrotizing fasciitis, which are really bad infections, that the surgery has to be done right there and then to prevent the infection from spreading and eating away at the tissue. All right, next is Charcot neuroarthropathy. So this is a complication of diabetes. So it's a serious and potentially limb-threatening lower extremity complications of diabetes. Usually patients that develop these are ones that didn't know they had diabetes, and all of a sudden they get redness, swelling, and then their foot turns really warm and hot, and they go see providers, and a lot of doctors think it's an infection. They put them on antibiotics, they don't get better, and then they end up following up with us, and we realize that they have diabetes. We take x-rays, we see that there's a lot of breakdown of their bones, so basically it's an inflammatory syndrome characterized by a various degree of bone and joint disorganization, secondary to neuropathy, trauma, and altered bone metabolism. And so the hallmark of this deformity is midfoot collapse or a rocker bottom shoe. So a normal foot would look like this, where you have an arch, and then with Charcot, the bones just disintegrates, and you develop multiple fractures. So if this is not treated right away, you can have long-term deformity of the foot, which can lead to ulcerations and callus and possibly a below-knee amputation if not treated correctly. But typically, if we catch this early, we're able to save the patient by immobilizing them, and we can prevent any breakdown at all. So it's very important to recognize it early. So this diagram shows you that, Charcot, which is the breakdown, can happen at different joints, right? There's 26 joints. There's different joints in the foot, and typically this illustration shows the frequency involvement of Charcot based on anatomic location. So 40% involves the Lisfranc joint, which is right over here, the middle of the foot. 30% involves the Chopard's joint, which is the joint kind of closer to the ankle. And then 15% involves the metatarsal phalangeal joints. And then to a lesser extent, the heel and the ankle. So how do we treat Charcot? So there's different ways that we could treat it. like offloading, right? That's the number way to do it if it's caught early before it leads to destruction. Typically, we put patients in a cam walker boot and we try to make them stay off their foot with like a scooter. And typically they'll be in that boot for like at least 3 months until we see consolidation on X-ray. And then after that, we put them in orthotics to make sure that their foot doesn't break down. There's medications that we can give to kind of help strengthen the bones. Obviously, the number one treatment would be to control the diabetes, right? You got to see your primary care doctor, you got to see your endocrinologist, you got to make sure your A1C is under control, because really, if that's not controlled, nothing we try is going to work. And then there's surgery. We can resect the infected bone or bony prominences that are causing the wounds or ulcers. There's reconstruction where we put an external fixator or rods or these long bolts in the foot to keep the foot from breaking down. And then amputation. Really, what the goal of surgery is to get a stable, ulcer-free, plantigrade foot. So as long as the patient's able to walk without any ulcers or breakdown, that's the ultimate goal. And this is kind of what it looks like. So you could see the redness, the swelling, kind of looks like an infection, rocker bottom, and this is kind of what happens when it's not treated right away. So this is just another, basically exactly what I said, just broken down into another pathway. So hopefully that wasn't too complicated. So really, how do we take care of our feet, right? Because we have diabetes. So you want to inspect your foot daily, right? Check for cuts, check for blisters, redness, swelling, or nail problems, right? An ingrown toenail can lead to an infection, which can get down to the bone if it's not taken care of. So you got to make sure you're taking care of that. If you can't see the bottom of your feet, use a mirror. Make sure you're seeing your podiatrist regularly, right? Patients come every 9 weeks, every 3 months, right? And if they're well controlled, maybe once a year, but they have neuropathy, definitely more frequently, like every 9 weeks, every 3 months. It's always good to wash your feet daily, lukewarm water, right? Because if you have neuropathy, you can't feel, you can give yourself burns. Always drying between your toes, moisturize your feet every day. With diabetes, it affects the autonomic system, and so you tend to be very dry in the heels and the arch. So there's a lot of different creams and moisturizers that we prescribe. Make sure when you're moisturizing, don't put anything in between your toes, because that can lead to breakdown of the skin, right? You want to put it really on top, on the bottom, not in between. Cut your nails carefully, right? If you have neuropathy, definitely have your podiatrist cut it. If you have peripheral vascular disease, let us do that for you. Don't try to take the corners down yourself. Some patients who try to do that or use medicated pads end up giving themselves ulcerations. And then that's how, it gets infected, because typically on the toes, there's not much tissue or fat. So really, breaking the skin can lead down right to the bone. You want to wear clean, dry socks. Make sure, like, if you're sweating a lot, switch your socks frequently. They do make diabetic socks, which don't have a tight band around the ankle, which is important if you have swelling, because that could lead to a wound. If your swelling is really severe and the socks are pretty tight. Don't wear socks to bed. This says wear socks to bed, never use a heating pad. This is kind of what the guidelines say. I would say don't wear socks. Just make sure you're wearing thicker blankets, because if you do wear socks and you sleep with socks, that can actually increase your chance of athlete's foot, because fungus kind of likes that dark, moist environment. And if you're, wearing socks and sleeping with them and you sweat, it's just kind of increasing your chance to develop athlete's foot. But so there's definitely other ways to kind of keep your feet warm. Always check in your shoes. Make sure there's no pebbles, because if you have neuropathy, which is nerve damage, a small pebble can lead to a wound, and you can get an infection. Right? Always keep your feet warm and dry in the winter. Consider using antiperspirant on the soles if you sweat a lot. There's certain medications that we prescribe for that. Don't walk around barefoot at home. Always wear slippers, right? You don't want to get a splinter, or step on glass. And the rest is, don't smoke, take care of your diabetes, and come see us regularly. So the shoes that you want to get is an in-depth Oxford. So you want a shoe with a wide toe box, so you don't get corns, calluses, or ulcerations. When you're shopping for shoes, you want to do it in the afternoon or evening because that's when your foot is the most swollen. And so you want to get the shoe that's added swollen, so that way that the shoe can accommodate that. Because if you get it in the morning, your foot's not as swollen, and then your shoe's going to be tight and bother you regularly. It's always good to stand when you're measuring your shoes because your foot gets wider. You should always break in the shoes and orthotics gradually to avoid blisters. Avoid wearing heels. 2.5-inch heel can increase the pressure on the forefoot by 75%. It's always good to wear white socks because if you have neuropathy and you do get a cut, you can see the drainage. If you wear dark socks, you might not notice it. And then, this is where the socks that are not too tight. They do make diabetic socks for that. Questions? Now, Kathy, are the questions in the chat or there's
They're
a
in
separate?
they're in the Q&A button on the bottom. Can you see it on your screen?
I don't. Should I hit stop sharing to see?
Sure. And do you see it on the bottom of your screen?
I think it's in a different section. Let's see. Yes, I do.
Okay, perfect.
All right. So the first question is, what level of A1C do you believe represents a fair one to think you are under reasonable control? So typically, right, a normal A1C for somebody who doesn't have diabetes is 5.5 or less. If you have diabetes, and then pre-diabetes is usually 5.7 to up to like 6.4, and then typically 6.5 is considered a good number to be at when you're diabetic. You're taking medications, that's a good range to be. As long as it's really under 7, you're probably in good shape. How do you recognize Charcot early? Are there symptoms? Yes. Yeah, so the symptoms are, pain, redness, swelling. Um, Typically, it's your foot kind of is very swollen, and it looks like you have either gout or infection. And so you're really gonna have to see a doctor right away, and so a lot of times if you go to urgent care, they might not recognize it right away, and so there's often times where by the time we get to see the patient, it's a little too late. But sometimes there's excellent practitioners that can recognize it and send them to us early. So but typically red hot swollen, that's a sign that you want to look for. What treatments do you recommend for neuropathy? Okay, so there's no treatments for neuropathy. Um, there's well, I guess I'll take that back. There's no cure for neuropathy. There's different treatments that we can do that won't cure the condition, but might make your condition feel manageable. So, with neuropathy, there's nerve damage. Nerve damage are not reversible. So sometimes we recommend patients, when they first get numbness, tingling in their feet, we try to tell them to take vitamin B12, B6, and folic acid. The nerves need these vitamins to work properly. And so patients, when they start taking it for a good 6 months, So 50% of patients will feel a significant improvement, and then 50% won't feel a difference. So that would be something that you could initially try. You can get like a complex B vitamin that has all these three things in it. And that could be something that you could try and see if it works. Other things that we can do is we can give you some medication like gabapentin or Lyrica. And so these don't cure neuropathy, but they help with nerve pain, which a lot of patients may have. They usually experience it at nighttime, and they have difficulty sleeping. Usually neuropathy is worse towards the end of the night. So oftentimes when we prescribe them these medications, we'll give it to them to help them sleep, but sometimes these medications can make you drowsy. So, so for some patients, they can't take it during the day. Um, and then, make sure you're lowering your A1C so the neuropathy doesn't progress. Make sure it's controlled. Physical therapy is always good to help with balance, because if the nerves don't work properly, it can affect your balance and you could lose muscle strength. So physical therapy would usually help with that. That's typically the options. Sometimes we make orthotics for patients to keep them comfortable uh, with their neuropathy, but most of the time there's you can't reverse it. So typically, what you would want, how much B6 or B12 do you recommend? So it's typically you would just take the daily dose. You don't want to exceed it. Too much of B6 can actually cause neuropathy. Certain studies. Okay, so yeah, so basically you could take the daily recommended dosage of B12 and B6. Like I said, if you get that complex, it's really all you'll need is just one pill that has it all in there. Uh, I have heard of gabapentin. Yeah, so gabapentin is a medication that we most commonly prescribe. Usually it's for patients who have a lot of nerve pain. This pain is affecting their ability to sleep. They can't sleep. They stay up all night. There's a lot of burning sensation in their feet. And so the gabapentin, we would start you off slowly and increase it until you feel that it's good enough to help you sleep and feel comfortable. But it doesn't cure neuropathy. It just treats the symptoms of neuropathy, if that makes any sense. Are gabapentin along with Cymbalta helpful for neuropathy? Yeah, so these are basically medications to treat nerve pain. So if you're having a lot of nerve pain, then they certainly can help you. But they're not going to reverse the numbness or the lack of sensation that you may have. Are there studies on B12 use that can be reviewed? Does B12 have any medication interaction? Yeah, so typically, B12 is relatively safe. I mean, obviously, one thing that you can do is, your primary care physician can test you to see if you're deficient in those things. And if you are, kind of, focus the treatment on, the vitamin that you're deficient in. Um, sure. Yeah, does alpha lipoic acid help neuropathy? Yeah, I mean, there's studies that show that it can certainly help the symptoms. Like I said, but it's not going to reverse the damage that was done from, the diabetes or the high A1C. Um, but typically, it can kind of keep it at bay so that way it doesn't continue to get worse, right? Because typically neuropathy is progressive, meaning it can get worse over time. All right. So if there's no other questions, thank you for your time, and I hope you guys learned something. And if you have any questions, you can reach out to me anytime.
Excellent. Thank you so much, Dr. Hanna, for your informative presentation this evening.
Thank you for having me.